Welcome, everyone, to the IMA Weekly Show brought to you by the Independent Medical Alliance. I'm Dr. Elizabeth Mumper. I'm a senior fellow in pediatrics with IMA. As you may have seen, measles is back in the headlines, and for many parents, it raises a lot of questions. Like, what does measles actually look like in a child? How serious is it? What can families do if someone gets sick? And what does the evidence say about treatment? And we'll also tackle the same kind of questions for adults. Today, we're actually talking about a new peer-reviewed systematic review published in Antiviral Research on the acute management of measles. Joining me are two of the paper's co-authors. Dr. Joseph Varon is president of the IMA, a professor at the University of Houston College of Medicine, and one of the most widely published physicians in critical care medicine. He actually has more than 1,000 peer-reviewed articles and decades of experience caring for seriously ill patients. We're also joined by Matthew Halma, Director of Scientific Research at IMA and a PhD candidate in biophysics in Amsterdam. His work focuses on evidence synthesis, molecular biology, and translating complex scientific literature into practical clinical insight. So thank you so much for both of you being here.
Thank you, Elizabeth. Thank you for having us.
Yeah.
Pleasure.
So in simple terms, what question was this paper trying to answer?
Well, the primary question that we saw was that there is clearly a decrease in the number of people out there that are getting vaccinated against measles. And people says, well, if I'm not getting vaccinated, what else can I do? So we actually decided to look at the literature and see what were the options. I mean, clinically, I can tell you, I've seen a lot of adults with measles over my lifespan. And, you take care of them mostly with supportive measures. But the question is there anything else that we can do? So Matt went ahead and with the help of a few other co-authors, we all worked together and started to look at what does the data really show.
So were you actually surprised by how much literature is out there about how to treat measles?
Not at all. I mean, I knew it. The biggest question, was why is this information not widely available? I mean, that was, I remember when I went to med school, man, they would just talk to you about vaccination as the only way to take care of measles. When I was a resident, I saw several adult patients with measles, and so even some of this information was kind of difficult to find. And the fact is that it's on plain sight. I mean,
yes.
It didn't take us too long to find all this information.
And so it sounds like the review covers both children and adults.
That's correct. And Matt will tell you how we actually did the whole, systematic review itself.
Yeah, so we looked through several hundred articles, looked through 5 major databases, and we were looking for any clinical evidence for antiviral treatment against measles in the acute phase. And yeah, we were left with a total of 10 articles, 6 clinical studies, 4 preclinical. So, it's more than nothing, but still, it wasn't a huge priority. It's to study this. So that's what our study does, is it sheds light that there's ways to manage acute measles. And
Yeah,
we're not doing this to disparage any other alternatives. It's just there's this issue out there. People are getting measles. Some people are, a certain percentage, it's a small percentage, have complications from this. So we looked at it and said, what can we do? And that's how we started.
and so
Yeah, I'm so
and
glad
so
you did it.
and so the viewers get an idea. I mean, we screen actually 1,571 different papers and records, and we excluded out of them 1,400. I mean, and then we basically started to look at, okay, which ones of these are eligible for what we're really interested in looking. Wanted to know, I mean, how many of them really have something on acute measles, which is an illness in of by itself, and how many of them were peer reviewed, because the ones that were not peer reviewed, we were not interested in looking at them.
Why do you think so many parents, and even it seems like so many clinicians, have heard so little about the acute treatment of measles? Because I was aware when there were 2 deaths in children in Texas, how they didn't really receive the kind of treatments that have been very well described.
I mean, at the end of the day, I hate to say this, but this is all about politics. It's about not having the amount of information that I mean, the data is there. There are things that you can do for patients with measles. And for one or other reason, we are not teaching that. My third daughter is a pediatrician, and she's a pediatric pulmonologist. And when I try to talk to her about these kinds of issues, you have I mean, you deal with colleagues of you who are pediatricians, and you know how there's like a barrier about this. Is so difficult to go through this. I think that this is information that should be taught in medical school and in residency. I mean, this, and I'm not telling you just to pediatricians. I think that every physician should at least be aware that there are options for these patients.
Yeah, I will say from my perspective, it seems like the acute treatment of measles has received a lot less attention than it deserves, and that people need to know how to take care of these people once they actually get measles. So, what are the biggest takeaways from your review, the sort of take-home messages for our audience?
Matt?
Yeah, so basically care, it starts with the basics, addressing the symptoms, and then going to some off-label options such as vitamin A, which is actually recommended by the WHO. And as therapeutic candidates, there's some good data supporting the use of ribavirin and interferon-alpha, sometimes IVIG, intravenous immunoglobulin. And there's some other therapies in the pipeline, such as some polymerase inhibitors and antibodies, but those are just in preclinical models. So, those haven't really been evaluated to the same standard as vitamin A or ribavirin. So, yeah, there's therapeutic approaches that are worth fleshing out further, but always with any research, you have to, it's always a start. It's not definitive at this point.
And I think that part of the most important thing is to remind people that measles still around. I mean, it's been around forever, and very few people get in trouble with measles. I mean, I don't know if you remember, Liz, when at least when my kids had measles, we would have other kids come in, and everybody would have like a measles party, so that
Yeah.
everybody would get the thing. Now, it's a little different in the adult, because adults do get complications, pulmonary problems. I mean, I remember some of the sickest people that I have seen have been people that have measles as adults, but usually they have other comorbidities. They have other issues that decrease their immune system. If you have an immune system and you get measles, whether you are a kid or an adult, you should be okay.
Yeah, I think that is a really important thing. I mean, I was born in the era when all of us got measles and we did share it. It's so highly infectious that, you can pretty much be sure that if you have a measles party, a lot of the kids are going to get it. But I think that the whole vitamin A story has not received the attention that it needs. That has very strong evidence. And I noticed that in your paper, you quoted for children 200,000 international units a day for 2 days. I have actually seen recommendations up to 400,000 units of vitamin A for 2 days. And I think it's important to understand that with the current kids who eat, McDonald's nuggets and French fries and rare vegetables, that they're not necessarily have gotten the yellow, orange, and red vegetables that would make them have adequate vitamin A levels. So I think the first thing to do when measles goes around is to start working on your nutrition and get your vitamin A levels up. So your paper, as Matt enumerated, discusses the vitamin A, the ribavirin, the interferon-alpha, IVIG, plus nutrition. Can you all talk a little bit, maybe you, Joe, about clinically how you would pick one versus the other? And in the paper, you talk about, the people that aren't really sick at all versus the people that are mildly ill versus the people that are very sick.
Well, like anything else in medicine, it depends on how sick the patient is. When the patients come to the hospital, let's say an adult that comes in with pulmonary complications of measles, you basically do what I call the gunshot approach. You're basically throwing the whole kitchen sink at them, and you give basically all of the therapeutic interventions that you discussed. But if you have a mild case of measles, you are at home. I mean, I usually do just the vitamin A, and that does the trick. I mean, I don't put every kid or every adult that comes to see me on ribavirin or stuff like that. Again, this is a self-contained illness for most cases, and we need to get that fear away from people. I mean, we're talking about measles like if it's something completely deadly. Yes, there can be complications. They can be encephalitis. They can be pulmonary complications, but they are low. So one of the things that you mentioned, which I think is extremely important, is instead of getting so freaked out about measles, why don't we just take care of making sure that all of us have enough vitamin A around in our systems? Because that would be one of our number one lines of defense against this illness.
I agree. And from a clinical standpoint, how much of a difference can good supportive care make in the outcome of a viral illness like measles, especially if you're starting with someone who's got good nutrition?
All of these patients will do well. And when I say all will do well, but like you said, you have to have good supportive care. And a lot of clinicians forget about these basics, They may start the ribavirin and forget the vitamin A, when the vitamin A is probably better than the ribavirin.
Yes, I do think that vitamin A is better than the antivirals, at least from the evidence so far. So how could families think about treatment if a child or an adult in their family becomes sick?
Well, I mean, there are several ways by which the first thing is, they need to talk to their healthcare provider and see how sick the kid or the adult is. As a rule of thumb, any adult with measles, I think they need to be seen in an emergency department setting, because many of them can deteriorate really, really fast. So I like to at least get imaging studies, you do X-rays, CAT scans, all sorts of things, and then you make a decision whether you keep them in the hospital or not. Now, for kids that have measles, I mean, most of them just take care of them at home and they do well. And then just be vigilant, and if there is an issue or a complication or whatever, you just move forward with additional therapeutic interventions.
Yeah, and as with many, oh, go ahead, Matt.
Oh, sorry. I was just going to note that there is measles burden worldwide, but it tends to be in lower income countries. So there's roughly 100,000. It's mostly children that die from measles per year. But if you think of the U.S. case, it's it's a major story if a single child dies of measles, and that's tragic. Don't get me wrong, but it's it's an issue that's very it's very it's very rare in higher income countries which have adequate nutrition and a medical infrastructure. And that's also what our study is looking at, is because we're looking at what are the low cost ways that we can reduce measles mortality and morbidity. And this is potentially useful for lower income countries because they might not have the same medical infrastructure. They may not be able to do preventative care as well as higher income countries. So that's another benefit of this, of why we did this study.
Yeah, I was actually surprised by the mortality figures that you quoted. In the paper, it was in high income countries 0.1 to 0.3%, and then in developing countries 3 to 6% for mortality. And I've seen some criticism of those numbers because the number of people that get measles versus the number of people that come to the attention of medical care in terms of either being hospitalized or seeing a doctor can be very different. And so at one point, you talked about how in some series as many as 40% were hospitalized. And that, I think, is very unusual in a high SES country that has basically, access to public sanitation and refrigerators and those kinds of things, because measles actually started declining before we had the MMR vaccine because of some of those other general measures. So people might want to know, what does measles look like in the early stages? Because one of the conundrums is that people are sick before they get the rash. So you're going to have people be sick and spreading measles before you know that that's what it is.
Yeah, and this is usually either an adult or a child that has a little bit of a low-grade fever, doesn't feel well. They are kind of, in kids, they look kind of sad. You don't know what they have. They may or may not develop a little lesions in their mouth that appear sometimes before the characteristic skin rash. And the rash comes in, I call it in all shades. It can be a very aggressive, very nasty looking, but it can be very mild. So it really depends on how much virus you have on board. Like I said, the most important thing, what are the defenses of this kid has? What is the immune status of the kid or the adult before they get the measles?
Yeah, the Koplik spots that Joe talks about are across from the molars, and they're considered to be pathognomonic for measles. In other words, if you see that in a setting where the child has a little bit of a cough and maybe a runny nose, you can really make the diagnosis without having to have lab testing. So from the literature and from your clinical experience, Joe, what complications show up the most consistently? You've mentioned pneumonia for adults, but there are some very rare neurologic complications that we sometimes even see in children.
Yeah, I mean, I have seen a variety of complications. Encephalitis is one of them, which is something that you don't want to see. But you can have even long-term issues with hearing, issues with eyesight. Depends on what part of the brain gets involved. So those are the ones that you don't want to have to get in. And every time I see a kid or an adult that is sicker, that I don't feel that should be cared for at home, those are the ones that you put in the hospital. And those are the ones that get the whole enchilada. We give them the whole thing. So they get their vitamin A, they get the ribavirin, they get whatever else needs to be done to get them better.
So, Joe, are adults at risk for different complications in children, or just they typically have more severe disease when they get it as an adult?
From what I have seen in my lifespan, they have more severe disease, and they tend to have more pulmonary complications than central nervous system complications. So I have seen people that develop the acute respiratory distress syndrome, which is a very difficult thing to treat despite of supportive therapy, and that has actually high mortality rate. On about 40% or 50% of patients may die if not cared appropriately.
Do you think this information about treatment strategies has been under-discussed or overlooked or perhaps even censored?
I think it's a combination of all of them. We are taught in medical school that the only way to fix measles is not to get measles, and you are taught that you need to get a series of vaccines for it. But one point that we have not discussed is that I have seen a variety of patients throughout my life span that have been vaccinated against measles, and they still get measles. And that's one thing that people need to understand. Measles vaccination does not guarantee that you're not going to get measles.
I think that's such an important point, Joe. You probably remember all the brouhaha about the Disneyland measles epidemic 5 or 6 or 7 years ago. And it turned out when they actually serotyped the types of measles that the patients had, I think it was as many as 45% were actually vaccinated. And even though infants usually get their first MMR vaccine around the age of 1, they had to add in a second vaccine before kindergarten because there were 5% of the kids that didn't even really respond to the first one. So I appreciate the fact that MMR vaccine coverage, when it's very high, can be protective. But honestly, we've had outbreaks in colleges where MMR vaccines being up to date was a prerequisite for admission. So the rates were like 98 and 99%, which theoretically should be enough for herd immunity. I guess there were a few exemptions for people that couldn't get the vaccine because of contraindications, but they still had measles outbreaks. So do not assume that because you've been vaccinated, especially if it's been a long while, that you're going to have lifelong protection. But if you actually get measles, you do have lifelong protection. So that's one of the benefits, actually.
It does, but the one thing that people forget is that once you get measles, you have actually the measles infection. One of the hallmarks of measles is that it gives you a very profound immune suppression. You kind of deplete your B and T cell memory, which are the ones that kind of like tell you what you have been infected with and what to remember. And the problem is that increases the risk of having other infections. So you can have, after you have measles for weeks and sometimes months, you can get a variety of different infections. So that's one thing that people need to recognize. And that's why it's so important to keep your immune system up to speed.
And I'd like to add, Joe, that there have been some epidemiological studies showing that if you have had measles, you're actually at less risk for certain types of cancers and certain types of inflammatory bowel diseases. So I kind of like to try to keep a balanced view of, viruses are something that we kind of need to coexist with. So how can doctors discuss prevention and treatment in a very balanced way? And how might this affect risk-benefit considerations for patients who are trying to make decisions?
I think at the end of the day, any healthcare practitioner, any professional that is talking to a family or whether adult or kid, we have to be honest with them and tell them the good, the bad, and the ugly of both the disease entity as well as the therapeutic interventions that you have or preventive interventions. I mean, if you're going to talk to them about vaccination, well, you need to tell them the good, the bad, and the ugly of vaccination. If you're going to talk to them about vitamin A supplementation, the same is true. You just have to be honest with your patients so that the patients can have the opportunity to do a truly informed consent on whatever therapeutic intervention you are going to do. And unfortunately, that's one thing that we don't see in clinical practice. You know, we have all these algorithms that everybody has to get this, and this. But how many doctors really sit down with the patients and talk to them about, hey, let me explain to you why you need to do this and what are the potential complications? I think that that's something that, you know, as a society, we have forgotten how to do it. And it's time that we reintroduce that concept. I mean, you know, that the IMA, we have been very vocal about this. We want to make sure that patients have all the information that they need so that they can make a nice, logical decision.
So, Matt, I wonder if you'd want to weigh in here from your specific set of expertise areas about when families ask their doctor what future immune benefits there are to the natural infection. What does the scientific literature tell us about that? And what is well established about the immunity you get after infection versus the immunity after vaccination, which I alluded to a little bit earlier?
Yeah, on that question, I am aware of in some cases, especially with adults, there's this immune suppression that Dr. Varon speaks of, and this can potentially be longer term lasting. As for the differences in immunity, I'm not familiar with that literature. I think I'll give it to Joseph if he is if he has a better response.
And again, I mean, I think we discussed at least what happens as far as the measles virus in of by itself. You know, again, immunity. You need to remember that immunity that you have, your baseline immunity, is going to determine how good or how bad you are. But after you have the measles, remember that your immune system is still going to be affected, and that beautiful immunity that you had before may need a little booster because you will get infections. And, you know, we have seen people that develop, let's say, a staphylococcus infection, you know, classic staph infections. But you can have people that have bad pneumonia related to an infection, problems with diarrhea, you know, the middle ear issues that, you know, kids tend to get. And this we have seen particularly in kids and adults coming out from Africa, where malnutrition is very prevalent.
So let's move on to a section where we try to make this really practical. If measles is circulating in a community, what are some reasonable steps that parents can take without panicking about it? We've seen so much panic about measles, but it's important to put it into perspective for families.
Well, you know, when I was working in the ER full time, every time I would get a case of measles, I would call my wife and I would say, bring my daughters in now so they can get exposed to this. So the first thing is, you know, don't get too stressed because, you know, stress can also get you in trouble. That's number one. Second, if you have a kid or an adult that has a good immune system, I mean, yes, you don't want to get exposed to the measles person, at least not the way we used to do these measles parties. But I'm not sure that keeping the people away and, you know, and keep them in complete isolation is the way to go, because that's what I have been seeing that's happening. Somebody gets measles and, you know, they get into an isolation room, which I'm not sure that that's good. Both especially when you're dealing with a kid, you know, I mean, psychologically, that's terrible.
So let's talk about what parents might want to have in their medicine cabinet just to kind of be ready for doing supportive and comfort care at home, because the reality is that that's going to be the case for most children who get measles, assuming that they have a good immune system. So what things would you think about talking to them about, Joe?
The first thing that I would say is make sure you have fluids that have electrolytes. Whether you like your Gatorade or something similar, or your even your therapeutic solutions that are out there, whatever kind of fluid, so that once you see that the kid is starting to get sick or the adult is getting to get sick, one of the reasons why they get in trouble is because they lose volume. They are sweating too much. That's where the kidneys start suffering. That's number one. Vitamin A, I mean, it's dirt cheap. You can find it anywhere. Just make sure you have a good amount of vitamin A at home. And we talked about the doses earlier, but you can find them pretty much anywhere in the literature. In our paper, as you saw, we went for 200,000. You have mentioned 400,000. Some vitamin A is better than no vitamin A. So that's one thing that I don't think that people need to have anything else at home other than maybe a little Tylenol or something for temperature control. And remember, temperature is the other thing. I mean, believe it or not, temperature is protective. People tend to treat temperature. I don't treat temperatures unless your temperature is more than 1 or 1.5. Because your body, once it has this elevated temperature, produces a series of proteins which are called heat shock proteins that help you get rid of the infection, and as well it helps you in case that you're going to have like a second increase in the temperature. So I kind of let the body do what it's meant to do, and unless obviously the kid or the adult are very uncomfortable with the temperature, then that's when I start using simple things like the Tylenol. Make sure that their clothing is relatively loose. Sometimes you can do a little vent just to improve circulation of air in the home. I mean, those are the simple approach. I don't know what else do you do, Elizabeth. You've been doing PIDs for much longer than I've been doing.
Yeah, well, I try to convince people that fever is their friend. It's a signal that their kid is sick. But my number for treating a fever is actually 102.5. And sometimes I'll even let them go higher. If they're running around and happy, the main concern I have with fevers when they get high is, number one, they need more hydration. So they have to drink a lot. And number two, there are a small percentage of kids, it's about 1 in 33, that is prone to having seizures with fever. So that's one reason not to let a fever stay very high. But unfortunately, most seizures with fever come just as the fever is starting to shoot up. So the parent is not necessarily going to know about that. I'm a big fan of vitamin D as an anti-inflammatory because it actually acts against some of the pro-inflammatory messages that kids tend to get. So I think that if we can just get parents to understand that in previous generations, measles has been pretty much widespread among children. And I would just say that there are some warning signs for both children and adults. You can comment about them, Joe, and then I'll add in a few if I think of some for Pete's that you don't mention. But what would you think that people might want to look at?
The way I look at it is I look by systems. So from a neurological standpoint, if the adult or the kid is starting to get confused, is starting to have a seizure or something like that, that's a moment that you have to take that kid to the hospital or that adult to the hospital right away. From a respiratory standpoint, if they start breathing a little too fast, if they start getting a little bluish discoloration in their mouth, or if you have one of those pulse oximeters and you see that their oxygen is going down, that's a reason for hospitalization. from a cardiovascular standpoint, if the heart starts going fast, if it's having, in the adult, if they're having palpitations, and if you have an adult that may have a coexistent condition and they start having chest pains or stuff like that, that's a reason for hospitalization. From a renal and metabolic standpoint, if the kid is not peeing, if the kid is not going and having urine, same for the adult, it's probably time to, get them to the doctor, because either you're not giving them enough fluids and they may need an IV or stuff like that. And from a stomach and intestine, one of the things that I get concerned about is when the kids start having a lot of diarrhea, and the adult as well, That's to me, those are like the red flags that would be a concern.
Yeah, diarrhea is actually quite common with measles. So I would tell parents to expect that, but if there's a lot of diarrhea, it becomes more difficult to keep up with the electrolytes and the fluids. So Matt, I realize Joe and I have talked a lot about clinical stuff, and I feel like I've left you out a little bit. What would you want to have families know about this review? Are there any issues about what you learned from doing such an exhaustive review, or how that's done, that you would like to talk about to sort of explain the scientific process that you went through?
Yeah, well, this review, it's a bit there's different elements to it, and some of the elements are more removed from the clinical experience, the parents' experience. That's more, my that's more where I focus personally, and so, I think the most important thing is that there are therapeutic options, and these should be explored. And I think it makes sense to explore treatment alongside prevention. That should be a no-brainer, really, and it shouldn't be controversial. Yeah, so I think there's a pipeline from preclinical to actual adoption, and I think we can push things along that line by doing more studies, accumulating evidence, and then using that to change guidelines. Like that's how treatment changes over time with new science. So the takeaway is that the way things are now, it's not fixed, and we're not at some point of total enlightenment. We're always evolving our knowledge.
Good point. And then Joe, what would your takeaway message? What would you want parents and clinicians to understand about measles treatment based on your clinical experience and your involvement in this literature review?
First, again, before they even talk about treatment, is first, don't get scared.
Yes.
Let's get back to the basics. We don't need to have panic. Measles has been going on for thousands of years. It's nothing new. I mean, we all have had, at least I can tell you, I had measles. I'm sure that you had measles as a kid, Liz. I mean, we're still around. I mean, so there are therapeutic interventions that we can do to make them better. One of the interesting things is that one of the therapeutic interventions, vitamin A, is also a preventive intervention. So you have an intervention that actually you can even start doing routinely for your kid or as an adult, and your chances that you will have complications are very small. Now, if you get into the complication situation, that's where my intensive care cap comes in. There are things that we can do for you. I mean, you are not going to just die. I mean, people that die usually have coexisting conditions. They have some other form of immunosuppression. They have severe malnutrition. They may have heart conditions. They may have some other things that make them prone to have that unfortunate premature demise. So in general, with good supportive care, whether it's basic measles or complicated measles, most patients should be okay.
And I would just like parents to know that if measles is circulating in your community, that's a great time to stock up on red, yellow, orange vegetables, sources of vitamin C. I would like to see the vitamin C, the vitamin D, and the vitamin A status of your child be really optimal. If it is, they are going to do very well if they happen to get measles. And with that, I think we have come to the end of the discussion session. And I thank you both so much for getting this paper out there. It can raise some awareness. And thank you for being here.
Thank you.
Thank you, Liz.
And now it's my pleasure to bring Autumn on with some questions for our experts. Autumn?
Yes. Hello, all. I have a few questions here for you, so I'll try to keep it quick. The first question that I wanted to ask, in the therapies you reviewed in the scientific article, are some of them for more immediate early treatment and others for more advanced cases?
I would tell you that, like anything else, and just like we learned in COVID, early therapy makes a big difference. So I would tell you that all the therapeutic interventions that we talk about, the sooner you can start them off, the better off you are, especially in cases that are complicated. As far as the vitamin A, like we discussed earlier, I mean, you want to start it even before you get the measles, so that when you get the measles is less intense.
Mm-hmm. Vitamin A, can you mention again what food sources are good? Also, can you get enough in food once you are acute, or will you need supplementation?
I would say that for most children now, they don't necessarily get enough vitamin A in their foods. If you have parents that fed you such that you got a lot of savory foods and a lot of vegetables early, that's fantastic. But if, as many parents do, with good intentions, they often start bananas and applesauce very early, and that conditions the child to sort of favor sweet things. And then they tend to reject some of the vitamin A containing foods. So things that are yellow, red, and orange tend to be high in vitamin A. And there's a crossover between foods that are high in vitamin A and high in vitamin C, which is great because vitamin C is another thing that you'd really like to have your child take in on a regular basis. So this is my plea for parents to really pay attention to the way you condition your babies early on to accept tastes that aren't sweet.
Yeah, really important. Overall, how does this research review on therapies impact how you advise on the risk/benefit analysis with your patients? Also, what comorbidities make measles more dangerous to patients?
I'll tell you that any comorbidity makes measles worse. Of course, if you're a diabetic that has poorly controlled diabetes and your sugar is sort of out of one, you can get in more trouble. If you have cancer, that's that's a bad one. If you have HIV or any other similar situation. So any pre-existing condition in general will do it. I'm particularly concerned from a respiratory standpoint when I have patients that have pre-existing asthma, chronic obstructive lung disease in the adult population, because I know it's going to be, as measles likes to hit the lungs, that's going to be I'm going to be fighting two diseases at the same time.
Dr. Mumper or Matt, did you guys have anything to add to that?
I just am really wanting to emphasize that parents shouldn't be so afraid of measles, and to realize that for the vast majority of children, they're going to do well unless they have something like leukemia, for example, childhood cancers of various types. Those children are the ones that I would want to protect. But I do think there's kind of a benefit from a healthy child getting measles because then they have lifelong protection. So if they have it as a child when they tend to do very well, they won't get it as an adult when they're more likely to get a measles pneumonia or a measles encephalitis. And they do get, at least the epidemiologic studies suggest that even though it does temporarily suppress your immune system, it's associated long term with less cancer and less inflammatory bowel disease. So I think it is not a disaster at all when children get measles, and with mostly supportive care and good nutrition, they should do well.
Dr. Mumper, with fever, we hear concerns about using Tylenol with young children. Would you still recommend Tylenol, or would you recommend different treatment options for a fever?
Well, my favorite treatment for fever is to put the child in a tepid bath. That means not so cold that they're going to shiver as a way of trying to generate heat, and not hot, which is going to add to the problem, but kind of lukewarm, drizzle it down over their shoulders. You can usually bring a temperature down at least 1 or 2 degrees without having to give medications. There is a concern about giving ibuprofen to children under the age of 6 months because it can be hard on the kidneys, but 1 or 2 doses intermediately is not going to particularly usually be a problem. Tylenol has the problem that it depletes something called glutathione. And glutathione is our best intracellular antioxidant. And when people are sick, they're under oxidative stress. So too much Tylenol actually is going to backfire in that it can give you more oxidative stress. So you may well have brought the fever down. It is very good for doing that, but you may stress the children's ability to detoxify and their ability to combat their oxidative stress. So I very sparingly use Tylenol and ibuprofen. I typically don't treat fevers if the child is not symptomatic in terms of having a rapid heart rate from the high fever or starting to get dehydrated from the fever. I will live with a fever in general, everything's individualized, but under 102.5 and not feel like I have to treat it. You'd be surprised how many calls I've gotten in my career from parents who call because the child has a fever of 99 degrees. And even though it is true that the average body temperature is 98.6, we all fluctuate through the day. And late in the afternoon and evening, when parents are coming home from work and taking their child's temperature, they'll often have a temperature of 99 degrees. I think that is not a true fever. And I would just caution them to not overtreat it. It is very adaptive in terms of mobilizing your immune system at this slightly higher body temperature to do a better job of getting rid of the virus.
And having said that, one of the most difficult things that you and me have seen in clinical practice is to convince the parents or, even my own nursing staff that no, we don't need to treat that fever. I mean, I put somebody in the hospital and I get the phone call, hey, fever is 100.5. Can we give Tylenol? When you say no, wait until it goes higher. People look at you like, what are you doing? So I'm just letting the body do what it's designed to do.
Another question we have is, how long are children and adults generally contagious with measles?
Liz, you want to go for kids?
Yeah. So, this is the really difficult part of measles is that for the first 5 to 7 days, they're in this very high replication phase where the measles is rapidly reproducing. And this is before they even have signs of the rash. They may have a little bit of a cough, a little bit of a runny nose. Sometimes their eyes get kind of red, but they're very, very contagious during that pre-rash point. Once the rash comes, you're actually starting to clear the virus, and I'm less worried about the child clinically. But the incubation period can be fairly long, up to 21 days. So even though measles is very contagious, the people that you have exposed may not break out in the rash for a while. And so that's one of the things that I think contributes to the R naught, or the replication number of, I think it's like 12 to 15, meaning it's one of the most highly contagious viruses that there is, because you're rapidly replicating the virus before you have the rash. And you don't necessarily feel that bad when you're a kid who has early measles. So that's the tricky part, is this whole contagion before you have the outward sign of the rash coming.
Yeah, I remember in medical school, they used to tell us, it's 4 days before the rash comes out and 4 days after the rash appears. So, I mean, you are talking about a fairly long infectious potential.
Yes.
Well, before I move on to closing announcements tonight, is there anything else that you guys would like to mention or leave our audience with before we wrap up?
I just would caution people about trying to put the news that they get in perspective. In journalism, there's a saying, if it bleeds, it reads, meaning that things that are scary or, kind of provocative tend to get a lot more coverage in the age of the internet. It's called clickbait. Mm-hmm. So you'll hear about the kids that died. You'll hear about the kids that are in the hospital. You won't hear about the hundreds of children that got measles, stayed at home, maybe didn't even go to the doctor. So try to get that balance and recognize that media, by its very nature, is going to go more for the sensational story. It's not that exciting to report that 300 kids in your community got measles and stayed home.
Mm-hmm. It's interesting that you mentioned that, because just a couple of days ago, I did an interview for a local TV channel where they were asking me about, there was a measles outbreak in jail where they have 7,000 inmates. And they didn't know what to do with the 7,000 inmates. It's like, again, most of those 7,000 inmates, I'm sure that they have some protection, because, most of adults at some point in time had the measles or had some immunity given to them. So the fact is that we don't need to freak out. They wanted to literally not release, or at least move 7,000 inmates because they had one case of measles in the jail.
Oh my goodness. Wow. Seems a bit overkill.
Yeah.
Matt, do you have any closing thoughts before I move on to announcements?
Yeah, I'll just say, science, the focus of science, it's dependent on structures and funding, and that's a major thing. Like with COVID, you see a huge amount of focus and dollars going towards the vaccines, but a comparatively small amount going towards treatment. So, yeah, treatment. If you are worried about the effects of measles, we should be looking at treatment. That's only a very natural.
It's the logical conclusion.
Very, very logical conclusion. And yeah, there's treatment available, and we did this. We did this not as an anti-vaccine article. We did it as a solutions-oriented article. Like, what can we do given that this is the case? People are worried about rising measles cases, so we're looking to interface with the scientific community on this, and come to areas where we can contribute to their understanding, and have a positive impact on on health.
Yeah, absolutely. Well, thank you so much, Dr. Mumper, Dr. Varon, and Matt for joining us tonight. I will move over to our closing announcements now. All right, so next Wednesday, March 18th at 7 p.m. Eastern, we hope that you will join Dr. Paul Merrick, our IMA Chief Scientific Officer, and Dr. Ryan Cole, IMA Head of Medical and Scientific Affairs, here's the graphic, for an important conversation on drug cycling in cancer care, what it is and why it's critical. This episode will be based on Dr. Merrick's newly published paper, so we hope that you will join us next week. When institutions disagree, parents deserve a calm, evidence-based place to turn. The Parents First Project will help families understand what changed, where experts differ, and what questions to ask at their child's next doctor's visit. Your gift helps make this independent resource free to every family who needs it. And right now, it goes twice as far. Every dollar up to $250,000 will be doubled, thanks to a generous donor. With your support, IMA can build the needed resources, such as a searchable childhood health resource created by independent pediatric experts, and training and educational resources, CME-based, for professional pediatricians and general practitioners to educate them on the risks of childhood vaccines that they may not be getting from their system-led medical education. Help us build this resource for families and professionals. You can learn more and donate at imahealth.org/parents. Next Thursday, March 19th at 6 p.m. Eastern, join the Independent Medical Alliance for an X-Space discussion, IMA Post-ACIP Roundup. You'll hear from Dr. Kat Lindley, Dr. Ryan Cole, Dr. Renata Moon, also Dr. Catherine Welch, and Dr. Daniel Stock, as they break down the latest developments and what they mean for patients, families, and physicians. The ACIP meetings are scheduled for March 18th and 19th, and this X-Space will cover the IMA expert analysis and be open for questions. Our X handle is @HonestMedicine in case you aren't already following us. Well, before we close tonight, we wanted to share a short promo video for this year's IMA Medical Conference, Emerging Trends in Medicine. Join us April 17th and 18th in Dallas-Fort Worth area for 2 days of conversations with leading physicians and experts exploring emerging trends in medicine, chronic disease, diagnostics, and innovative approaches to patient care. If you'd like to attend, you can learn more and get your tickets at imahealth.org/conference. Now here's a quick preview of what's ahead. Thank you all so much for being here, and good night.
IMA is not afraid to touch those third rail topics. We're talking about alternative treatments of cancer. We're talking about holistic health. We're talking about Chinese medicine. We've got a panel just about the whole gender transition of minors, right? Who talks about that?
I know I can get access to state-of-the-art information about medicine, and I can trust the individuals that are speaking.
Healthcare professionals, don't miss this. Be part of the 5th Annual Independent Medical Alliance Medical Education Conference happening April 17th and 18th in Dallas-Fort Worth, Texas.
We are at a point in time where we can make a difference, and education is by far the most important.
It is so important to come to a conference like this because it just really restores your faith. It gives you the courage to keep going, to speak up.
Their quality of data, their quality of education, their love for people.
This year's theme, Emerging Trends in Medicine, explores the latest innovations, cutting-edge research, and forward-thinking practices shaping the future of healthcare.
Just having this Independent Medical Alliance family build, I love the humanity that comes to a conference like this because everybody has a story and everybody has something to teach.
I think conferences like this build community, an amazing forum for learning new things.
Connect with industry leaders, gain actionable insights, and be equipped for what's next in medicine. Continuing medical education credits available. Visit imahealth.org/conference to secure your spot today.